The subcommittee will come to order. I believe the clock's a little slow, so we'll get started. And I want to start by mentioning we have a couple of distinguished alumni in the audience of this committee. Phil Gingrey, who is a member of our subcommittee, welcome. Very distinguished member. Mary Bonamac is here. Where's Mary? She often raised this issue with me, so welcome. We appreciate all of your interest and input as well. The Chair will recognize himself for an opening statement. Today's hearing will consider a number of proposals intended to address various aspects of our nation's drug abuse crisis. The Oversight and Investigation Subcommittee has held 5 hearings examining this public health epidemic and current efforts underway to combat prescription drug abuse. It is clear that despite these efforts, the epidemic has continued to grow exponentially. Today is a good opportunity to better understand what Congress can do to help. I appreciate the administration witnesses being here and working with us on these complicated issues. I also look forward to the testimony of outside experts on these various bills in the near future. Prescription drug abuse does not discriminate. It is not limited by geography, income, or age. According to the National Institute on Drug Abuse, 1 in 5 Americans has used prescription drugs for non-medical reasons. In 2011, the Substance Abuse and Mental Health Services Administration published a national survey on drug use and health and found that 1.7 million 12 to 25-year-olds abused prescription drugs for the first time, which amounts to more than 4,500 new initiates per day. These startling statistics should concern all of us. Unfortunately, only about 10% of people with substance abuse disorders will get any form of medical care. There are many of our constituents and their families that still need help, and I applaud my colleagues for working on legislation with that goal in mind. I now yield to the distinguished gentleman from Indiana, Dr. Bucshon.
Thank you, Mr. Chairman. Congressman Womack and I introduced H.R. 2872 as a starting point that will eventually result in legislation that helps reverse the heroin and opioid epidemic. Over 100 years ago, Congress first began legislating opioid addiction treatment policies, and since that time, Congress has had to come together and pass such legislation time and time again. Given the worsening epidemic, it is time for Congress to act once more. H.R. 2872 is not a final product. To that end, Congressman Womack, Congressman Tonko, and I held the first opioid addiction treatment work group composed of the leading opioid addiction professional associations and other stakeholders to discuss our legislation. Our objective is to refine this legislation to become a bill that all the key stakeholders support. We can only reverse the opioid epidemic by effectively treating the underlying cause, and part of that underlying cause is our federal government's public health response to addiction. Clearly, what we are currently doing is not working well enough, and change is needed. We will need to treat addiction as a medical disease that it is, and confront the very real issues that prevent a person from receiving individualized care specific to his or her circumstances. We need to understand what the data is telling us, and we shouldn't allow the status quo to prevent legitimate deliberation over what is the best path forward for addressing a crisis that is touching all of our communities. These are the challenges that we must overcome. At this point, I also ask unanimous consent to submit for the record a statement from the American Association for the Treatment of Opioid Dependence.
Without objection, so ordered.
Thank you, Mr. Chairman. I yield back.
And I would like to ask unanimous consent to submit the following document for the record, a letter from the American Medical Association. Without objection, so ordered. The Chair now recognizes the ranking member, Mr. Green, 5 minutes for opening statement.
Good morning, and thank each of you for being here today. As we know, the Centers for Disease Control and Prevention declared our nation's prescription drug abuse crisis an epidemic. In 2013, drug overdose was the leading cause of injury death in the United States. This is a battle we have waged for more than 100 years. When Congress first passed laws to confront the problems of heroin and opioid addiction, we are once again faced with challenges of controlling and combating this menace, and that is ravaging communities across the country. In the past few years, overdose deaths involving opioids increased at fourfold, and the number of heroin users almost doubled. Cases of HIV and hepatitis C are on the rise. Despite universal recognition of the problem, our current efforts are not enough to meet the challenges of the crisis. The drivers of the problem are complex, and there is no single silver bullet solution. It is critical that we approach this challenge through a public health lens. Experts have documented serious impediments to widespread access to treatment, including a shortage of substance abuse providers, social and cultural stigmas, and lack of health coverage for such services. Current research suggests that a combination of medication-assisted treatment and behavioral treatment, such as counseling and support services, are the most effective way to treat opioid addiction. In 2013, medication-assisted treatments were available in only 9% of substance abuse treatment facilities. For example, in 2012, 96% of states in the District of Columbia had opioid abuse dependence rates higher than their butyrophyllene treatment capacity rates. 38 states reported that at least 75% of the opioid treatment programs, or also known as methadone clinics, were operating at a greater than 80% capacity. Today, we're here to examine 7 legislative proposals aimed at combating our nation's drug abuse epidemic. They build upon the hearings this committee has held and represent various approaches to improving prevention and treatment. Each is a product of thoughtful consideration and dedication from their sponsors, and I thank my colleagues for their efforts and the chairman for having this hearing. It's critical that we give law enforcement, health providers, and communities enhanced tools to address this epidemic. We need more resources and coordinated effort to ensure that evidence-based treatment is available and diversion is stymied. The statistics are staggering. The need for action is clear. Again, thank you for being here. And I'd like to yield 1 minute to Congressman Lujan.
Thank you, Mr. Chairman and Ranking Member, for scheduling this incredibly important hearing on a crisis that is plaguing our nation. This crisis touches everyone, from dense urban cities to rural states like New Mexico, where getting access to health services can often be a challenge. The most recent data from New Mexico's Health Department puts the accidental drug overdose rate at 24.3 per 100,000. That's more than double the national average. In 2 of the counties in my district, the overdose rate is more than 5 times the national average. Too many people are being forgotten, and too many people are suffering. That is why I've introduced the Improving Treatment for Pregnant and Postpartum Women Act to strengthen efforts to ensure that some of our most vulnerable get the care they need. I want to thank my colleagues, Representative Matsui, Tonko, Clark, and Cardenas, for joining me in introducing this bill, and I look forward to today's discussion and getting this done. Mr. Chairman, the thoughtfulness behind all of this legislation is so important, and I just hope that we can get this done. Thank you, Mr. Chairman. I yield back.
Mr. Chairman, I yield another minute to Congresswoman Matsui.
Thank you very much. Thank you, Mr. Chairman, for holding this hearing today on such an important topic. There is a growing prescription drug epidemic plaguing this country that we can no longer ignore. Prescription drugs are the second most abused category of drugs among young people, and sadly, these painkillers often serve as a gateway to cheaper street drugs like heroin. The abuse of both prescription painkillers and heroin is devastating families and undermining public health and safety in our communities. In order to address this epidemic, we need to engage the full range of players, including patients, providers, parents, and manufacturers, as they all can and should play a critical role in curbing the abuse of prescription drugs. Addressing this crisis should be a priority, and I'm pleased that this committee is holding a hearing on this important issue. I look forward to hearing from all the witnesses as we consider strategies for addressing this epidemic. Thank you, and I yield back.
Mr. Chairman, I yield the remainder of my time to Congressman Sarbanes, if you'd like to make a very brief statement.
It will be brief indeed. Thank you for yielding. One of the bills we're going to be talking about, or I'll be referring to, is the Co-Prescribing to Reduce Overdoses Act. This would allow for co-prescribing of naloxone when physicians are prescribing opioids in cases where the patient is at high risk for overdose. And it would allow for a demonstration project to support certain facilities in exploring this opportunity, training physicians on it, who in turn can train patients on how to self-administer this life-saving drug. We have an epidemic across the country. Certainly, Baltimore and Maryland is experiencing this, and we look forward to testimony today on topics of this kind. And I yield back. Thank you.
Mr. Chairman, I also like you to ask consent to place into the record a statement by the Drug Policy Alliance.
Without objection, so ordered. The gentleman yields back, and now the chair recognizes the gentlelady from Indiana, Mrs. Brooks, who's filling in for the chair of the committee.
Thank you, Mr. Chairman. I'd like to thank the committee for bringing attention once again to this important topic. Sadly, Indiana is leading the country, but not in a way we would like. Unfortunately, according to our state public health commissioner, Dr. Adams, Indiana is one of 13 states where the prescribers write enough prescriptions that every citizen in our state has a pain prescription. Unsuspecting addicts get hooked on opioids, but oftentimes they switch to heroin, not only for the high, because now it's less expensive and it's actually easier to get. And heroin on our streets is cheaper, stronger, and thanks to the synthetic add-ins, more unpredictable in its results than in the past. From 1999 to 2009, Indiana health officials have seen a 500% increase in the rate of drug overdose deaths, and in fact, overdose deaths now surpass motor vehicle-related deaths in our state. And it's not just the overdoses, but in this past year, as this committee has already heard, Indiana has seen a drastic spike in hepatitis C and HIV due to opioid and heroin infusions, with the most recent figure at 183 confirmed cases of HIV in one small rural county alone. Now, we've held lots of roundtable discussions with providers and with prescribers and with law enforcement, but tragically, it's the families of the addicts and of those who have died who have become the real experts in this field. The consistent thread in the debate is that 80% of heroin use starts with prescription for pain meds, and many prescribers are unaware they may be a major part of the problem. So there's no silver bullet to fix it, but that's why I'm very pleased that Congressman Kennedy and I have introduced H.R. 2805, the Heroin and Prescription Opioid Abuse Prevention, Education, and Enforcement Act of 2015. Yes, it's a comprehensive approach to solving the problem. It incorporates law enforcement, medical providers, educators, and first responders. I'm thankful to my colleagues for participating in today's hearing, and I look forward to working with them in the coming weeks to advocate not only for passage of this bill, but the many thoughtful solutions being proposed by this committee. I yield back.
Chair thanks the gentlelady. And now the chair recognizes the gentleman from Massachusetts, Massachusetts, Mr. Kennedy, filling in for the ranking member of the full committee.
Thank you, Mr. Chairman. I appreciate the opportunity, and I want to thank the witnesses for coming and testify today and for your extraordinary dedication to these issues and your service to our country. The other day, I asked some of my constituents to tell me about their experience with opiate abuse and drug addiction, whether it was their own personal struggle or the battle of a loved one. Their responses were heartbreaking. A grandmother who lost her 25-year-old grandson over the summer, a father whose 56-year-old son battled mental illness late in life and eventually fell victim to cocaine addiction, a young woman who had just lost her cousin to an overdose 2 weeks ago, a mother whose son was denied entrance into a treatment program last month because he was already in detox after overdosing. So she gave him the money he needed to buy drugs and test positive. The themes of each story were unique, but every constituent ended their message the same way, by calling on Congress to act. Many of the bills we are considering today will help us begin to answer those calls, including one I was proud to introduce with my colleague Congresswoman Brooks earlier this year. Chairman Pitts and Ranking Member Green, thank you for your continued commitment to this issue. I look forward to listening to the conversation today and discussing some bipartisan solutions. I'd like to yield the balance of my time to Representative Tonko.
Now I thank the gentleman for yielding. I'm pleased that we are holding this legislative hearing today on bills that aim to ease the burden of our nation's growing opioid epidemic. I'm here today in support of the Recovery Enhancement for Addiction Treatment Act, also known as the TREAT Act, on which I joined with my fellow upstate New Yorkers, Representatives Higgins, Katko, and Hanna, to introduce. This legislation would lift the current caps in place on the number of patients that doctors can serve while prescribing buprenorphine, a medication-assisted treatment for opioid addiction. Under current laws, if every opioid treatment program and Data 2000 waivered physician treated the maximum number of patients, there would still be roughly 1 million opioid-addicted individuals unable to secure treatment. The hope with this bill is that we can lessen this gap between individuals seeking treatment and our inadequate treatment capacity. While this legislation is not a cure-all and we still need to examine measures to ensure the highest quality care, I believe that TREAT Act will go far in helping to alleviate our acute treatment capacity issues and put more people on the path to recovery. I urge our committee to take swift action on this bill so that we can turn the tide on this epidemic. And with that, I thank you and yield back to Representative Kennedy.
Unless there's another member of the minority that wants time, I yield back.
Chair thanks the gentleman. That concludes the opening statements. As usual, all written opening statements of the members will be made a part of the record as well. We have two panels for this hearing. We're going to take one today, the second week of October 20th when we come back from break. But I'd like to thank our first panel here today, and I'll introduce them in the order of their testimony. First, we have Mr. Michael Botticelli, Director of the National Drug Control Policy, Executive Office of the President. Secondly, Dr. Richard Frank, Assistant Secretary for Planning and Evaluation, Health and Human Services. And finally, Mr. Jack Riley, Deputy Administrator, Drug Enforcement Administration. Thank you very much for coming today. Your written testimony will be made a part of the record. You'll be each given 5 minutes to summarize. We have a series of 3 little lights. So green will be on for 4 minutes, yellow a minute, and at minute number 5, the red will come on. We ask you to wrap it up if you could, and then we'll go to questions and answers. So thank you very much for coming, and Mr. Botticelli, you're recognized for 5 minutes for your summary.
Thank you, Chairman Pitts, Ranking Member Green, and members of the subcommittee for the opportunity to appear here today to discuss the administration's response to the epidemic of opioid abuse, particularly the rise in non-medical prescription opioid and heroin use, overdose deaths, and the use of new psychoactive substances. The Office of National Drug Control Policy produces the National Drug Control Strategy, which is the administration's primary blueprint for drug policy. This strategy treats our nation's substance use problems as a public health issue, not just a criminal justice issue. Using ONDCP role as the coordinator of federal drug control agencies, in 2011, our administration released a plan to address the sharp rise in prescription drug misuse. This plan contains items categorized in 4 areas: education of prescriber and patients, increased prescription drug monitoring programs, proper medication disposal, and law enforcement efforts. The administration has also convened at Congress's urgence an interagency heroin task force, co-chaired by ONDCP and the Department of Justice, to more closely examine our strategies as it relates to heroin use in the United States. The task force will release its strategic plan later this year. There has been a stark increase in the number of people using heroin over recent years and the number of overdose deaths involving heroin. As communities and law enforcement struggle with an increasing number of overdose deaths, heroin use, and increased heroin trafficking, it is important to note that plentiful access to opioid drugs via medical prescribing and easy access to diverted opioids for non-medical use is feeding our opioid drug use epidemic. Even though data indicate that over 95% of prescription opioid users do not initiate heroin use, 4 out of 5 new heroin users have experienced as non-medical prescription drug users. Given this interrelationship, the public health response to heroin use must be part of the response to non-medical prescription opioid use. A further complicating factor in addressing this epidemic is law enforcement reporting of heroin that is laced with fentanyl, an opioid drug that is estimated to be 100 times more potent than heroin. This increased potency has resulted in more overdose deaths in many parts of the country. We have seen overdose deaths from prescription opioids level off, but unfortunately this is coupled with a dramatic 39% increase in heroin-involved overdose deaths in 1 year from 2012 to 2013. To address the overdose death issue, we are working to increase access to naloxone for first responders and individuals close to those with an opioid drug use disorder, and to promote Good Samaritan laws so witnesses to an overdose will take steps to help save lives. First responders nationwide are rising to this challenge of addressing the increase in opioid use and overdose deaths. But the medical establishment also needs to increase access to treatment for individuals with opioid use disorders before they become chronic or result in other public health consequences such as infectious diseases or neonatal abstinence syndrome. Given that little to no time in graduate medical education programs is devoted to the identification or treatment of substance use disorders, and given that very few physicians have availed themselves of voluntary training options, our administration continues to press for mandatory prescriber education tied to controlled substance licensure. Evidence shows that medication-assisted treatment with FDA-approved medications, when combined with behavioral therapies and other recovery supports, has shown to be the most effective treatment for opioid use disorders. Our administration continues to pursue a wide variety of ways to increase access to these life-saving medications. But since some of these products are subject to diversion, it is essential that this expansion be done in a way that promotes high-quality care and minimizes the opportunity for diversion. It is also important to continue our efforts to educate the public about the risks and consequences of non-medical prescription opioid and heroin use and the availability of options for treatment for opioid use disorders to help improve and save lives. To help with all of these efforts, the administration's FY16 budget proposal includes $133 million in new funding to reduce opioid misuse, abuse, and overdose deaths. Lastly, a few comments about the use of new psychoactive substances, or NPS. The administration's activities to reduce the use availability of NPS include data collection, research, prevention, treatment, domestic and foreign law enforcement actions, and international cooperation to reduce the manufacture and distribution of these serious life-endangering substances. The health risks of NPS can be significant, including serious injury and even death. The contents and effects of synthetic cannabinoids and synthetic cathinones are unpredictable due to a costly changing variety of chemical compounds used in manufacturing processes that are devoid of quality control and regulatory oversight. These substances also contain toxic impurity byproducts, and the potency can vary significantly from batch to batch. In conclusion, this administration will continue our work with Congress and our federal, state, and local partners on public health and public safety issues resulting from the epidemic of the non-medical prescription opioid and heroin use, as well as new psychoactive substances. Thank you.
Chair thanks you, gentlemen. Now recognizes Dr. Frank. 5 minutes for your summary.
Thank you, Chairman.
Make sure the button's pressed. Yeah.
Thank you, Chairman Pitts, Ranking Member Green, and members of the subcommittee. I appreciate the opportunity to speak with you about addressing the misuse and abuse of opioids. We at HHS share your sense of urgency to take action to end this epidemic. Secretary Burwell has made halting the opioid epidemic a top priority. The numbers on the epidemic are stark. In 2014, more than 10 million people reported non-medical use of prescription opioids, and nearly 1 million reported use of heroin. Moreover, it's estimated that more than 2 million people have an opioid use disorder. These disorders tear apart families, increase crime, and kill too many of our neighbors. When Secretary Burwell arrived at HHS a little over a year ago, she directed our senior leadership to develop and implement an initiative to address the opioid problem. She insisted that it be department-wide, focused, and evidence-based so as to produce maximum impact. That effort resulted in a strategy that consists of 3 elements. First, improving prescribing practices for opioid pain medications. Second, expanding the use of medication-assisted treatment for opioid use disorder. And third, expanding the use and distribution of naloxone to reverse overdoses. In the time I have with you today, I want to focus on our efforts to expand the use of medication-assisted treatment, or MAT. MAT is a treatment that combines medication, behavioral interventions, recovery support services, and careful patient monitoring. There are 3 FDA-approved medications used in MAT: methadone, buprenorphine, and naltrexone. MAT, using each one of these, has been shown to be effective in clinical trials and in public health interventions. It is, in fact, the most effective approach to treating opioid use disorders. Yet MAT is woefully underused. Provision of MAT faces unique barriers, in part because methadone and buprenorphine are controlled substances. In addition, stringent medical management techniques are used to control utilization, and in the case of buprenorphine, the number of opioid use disorder patients a certified physician can treat is limited to 100 at any one time. Our approach to expanding the use of MAT is guided by, first of all, the recognized need to expand the use of MAT. 2, the fact that effective use of MAT means delivering the full package of services: pharmaceuticals, counseling, recovery supports, and monitoring for patient adherence. And third, that the capacity be expanded in a way that minimizes the risks of drug diversion. This approach is supported by the American Society of Addiction Medicine's recent guidelines on appropriate use of MAT. Given these guardrails, I want to share with you the steps we're taking to expand MAT that we believe have much in common with proposed legislation that's already been mentioned today, such as the TREAT Act. Following Secretary Burwell's recent announcement, we are engaging in rulemaking related to expanding access to buprenorphine-based MAT. Our Health Resources and Services Administration, or HRSA, recently announced a competition for $100 million to expand the use of MAT in community health centers. SAMHSA recently awarded $11 million per year for 3 years to 11 states across the nation to increase MAT, and is proposing an additional $25.1 million for this purpose to go to 22 states for fiscal year 2016. CMS recently issued a letter to state Medicaid directors describing opportunities and authorities that states can use to provide a continuum of care to beneficiaries suffering from substance use disorder, including opioid use disorder. We are also exploring ways to expand education and training for providers in the treatment of opioid use disorders. We are committed to tracking and evaluating our efforts so that we make the best use of public resources, and in the end, we will measure our success by the impact we have on families, people, and communities touched by the opioid crisis. Thank you.
Chair thanks the gentleman and now recognizes Mr. Riley. 5 minutes for your opening statement.
Chairman Upton, Chairman Pitts, Ranking Member Pallone, Ranking Member Green, and members of the subcommittee, I want to thank you for this opportunity to testify this morning about our nation's most pervasive drug issues, the continuing opioid epidemic and the rise of synthetic drugs. DEA's single mission is enforcing the Controlled Substances Act, and we are honored to work closely with our counterparts, including those in education, enforcement, research, recovery fields, as well as partners in the supply chain. Sadly, today, 120 Americans will die as a result of drug overdose. Heroin and prescription drugs cost over half of those fatalities. Accordingly, DEA views the opioid addiction epidemic as the #1 drug threat to our country. I spent my entire career in law enforcement, having been an agent with DEA for over 30 years. I have to tell you, I've never seen it this bad. Prescription drug abuse has increased tremendously in the last 15 years. The abuse of prescription drugs and the resulting addiction has fueled a spike in the use of heroin. In fact, 4 out of 5 new heroin users have misused prescription painkillers. Increases in heroin purity, its low cost on the streets, the expanding role of violent Mexican organized crime groups, and their toxic business relationship with violent urban street gangs has also played a significant role in the resurgence of heroin. DEA is addressing this evolving threat by targeting the highest level traffickers and the vicious organizations they run. I have personally spent the bulk of my career chasing the man I consider to be the most dangerous heroin dealer in the world, Chapo Guzman. He and his Sinaloa cartel clearly dominate the U.S. heroin market, as the map I've brought with me today depicts. Just as we cannot separate violence from drugs, we cannot separate controlled prescription drug abuse from heroin. As a result, DEA established highly effective tactical diversion squads, 66 in total, to target the critical nexus between the diversion of prescription drugs and heroin. DEA has also addressed the threat posed by the drugs that are in our medicine cabinets. Through our national take-back, the latest one being just 2 weeks ago, we have removed over 5.5 million pounds of unused and unwanted drugs. However, DEA drug disposal is still a problem to us, and we can't solve it on our own. DEA promulgated a regulation last year to allow the drug supply chain to become authorized collectors. At present, we have 500 registrants. It's simply not enough. This is one important way in which we can step up as partners in our effort to curb prescription drug abuse. Lastly, I want to address the growing synthetic issue that we're facing. Some of these designer drugs are referred to as synthetic THC and marketed as with similar effects. Nothing could be further from the truth. Last year, there was a 229% spike in calls to poison control centers for synthetics. The physical reaction to even one use of a synthetic drug varies widely, and in some cases has resulted in death. DEA has identified literally hundreds of synthetic drugs that have been encountered during federal, state, and local law enforcement operations. Manufactured in overseas laboratories, these drugs are unregulated, have no medical use, and are not tested for safety. This means that those who misuse these products, most likely our teens and adolescents, are really unwittingly allowing themselves to become guinea pigs. Law enforcement has been encountering these substances more and more. According to the National Forensic Laboratory Information System, substances identified as synthetic cannabinoids by federal, state, and local forensic laboratories have increased from 52 reports in 2009 to over 49,000 reports just last year. DEA has made several enforcement operations targeting this problem, including Operation Logjam, Project Synergy 1 and 2, which have collectively resulted in 377 arrests and over $80 million in cash seized and literally tons of synthetic drugs taken off our streets. These operations demonstrate the scope of the problem, but I believe they're really just the tip of the iceberg. I want to thank you for your partnership. DEA and I look forward to continuing to work with this subcommittee in Congress on these important issues.
Chair thanks the gentleman. That concludes the opening statements of the witnesses. We'll now begin questioning. I'll recognize myself 5 minutes for that purpose. Dr. Frank and then Mr. Botticelli. In your view, what are the most significant obstacles at the present time preventing more individuals with opioid use disorders from receiving the most effective treatments?
I think there are several factors. I think supply of treatment is certainly one important factor. Second one is stigma and the shame that comes from seeking treatment, the attitude of friends and neighbors. And then third, I think we're still working on our payment and coverage arrangements as we implement our parity legislation and as we move towards expanding our parity regulations.
Mr. Botticelli?
As you indicated, only about 20% of people who have a substance use disorder get care and treatment. And the factors that are often cited in those surveys, as Dr. Frank alluded to, is one, insurance status. And we know that either not having insurance or not having insurance that appropriately covers a spectrum of substance use disorder services is particularly challenging. As he also talked about, stigma plays a role. We know that in national data, and I hear it time and time again reflected in people's stories, that it keeps them from asking for help or delaying their care. And the third aspect, particularly as it relates to opioid use disorders, as we've been discussing here, is the really dramatic underutilization of medication-assisted therapies, not only in our treatment programs, but in our correctional facilities. We know we have many parts of the country that don't have a dedicated treatment program, and looking at, and I think particularly the Secretary's initiative focusing on increasing access to community health centers becomes particularly important. So we know that not having dedicated dedicated treatment in a local community is really, really important.
Would the two of you expand on that, on the role that you think medication-assisted therapy should play?
I'll start and
go ahead.
have Dr. Again, I think there's common agreement, and that all of the studies are really very crystal clear that by far people do better with opioid use disorders, do better on medication-assisted treatment when done in a high-quality way that includes other behavioral therapies and supports, bar none. So we know that not only do people do better, they don't die, they don't get infectious disease as it relates to it. And part of our efforts on the administration level, both at ONDCP in conjunction with HHS, is to ensure that people have adequate access. In addition to grants and other activities, we've also been strengthening our federal contracting language to ensure that those programs that get federal dollars that support treatment include the entire spectrum of FDA-approved medications for opioid use disorders.
Dr. Frank, you want to add to that?
The one point I would add to that is that it's not only important that we have people out there able to conduct medication-assisted treatment, but they have to do it in a way that is evidence-based. That is, having all the components in place: the counseling, the recovery supports, the patient monitoring. You need the whole package for it to work. But clearly, when you have that, it is the most effective treatment out there.
Thank you, Mr. Riley. I appreciate DA's willingness to work with the committee to ensure that veterinarians can travel with and administer pain medication to their animal patients. Athletic team physicians also have an inherently mobile practice. Yet, as was the case with the vets, the statute prohibits them from administering appropriate medication to their patients outside of their physical office. Will you commit to working with the committee and Chairman Sessions on a responsible solution to this important issue?
Well, yes, sir, we will and we are. This is a difficult balancing act in terms of making sure that the supply is there to legitimate patients given by legitimate caregivers. But we also want to make sure that the ability of diversion in these situations are as limited as much. So I look forward to working with the committee, and I know we already are, sir.
Thank you. I also appreciate DEA's efforts to combat the recent influx of incredibly dangerous synthetic drugs hitting communities across the country. Yet I understand that due to no fault of your own, the criminals are a step or two ahead of you. Can you explain how Congressman Dent's bill would help in this regard?
Well, first of all, I want to say thank you to the leadership in this issue, because it really is an issue for us. As I look across the country today, what keeps me up at night is clearly the heroin issue, the opioid addiction issue, various organized crime groups, but second to that is the growth of synthetic drugs, primarily targeting our young people. I personally witnessed this where people have lost their lives. So from a cop's point of view, sir, and that's what I am, anything that could help us as a tool to make sure we can move quicker, we would welcome. And again, we're going to work with the committee to get it done.
Chair, thanks, gentlemen. I recognize the ranking member, Mr. Green. 5 minutes for questions.
Thank you, Mr. Chairman. Current research suggests that the most effective treatment to combat opioid addiction is a combination of medication and counseling. Methadone, which was approved nearly 50 years ago as a synthetic opioid, methadone is also a DEA Schedule II drug. Director Botticelli, can you talk a little bit about the evidence-based regarding methadone and how it impacts patients' retention and treatment, transmission of infectious disease, and other health outcomes?
So methadone is one of the most highly evaluated treatments for opioid use disorders. It's been around for over 50 years. And so not only have we seen kind of remarkable results in terms of treatment engagement and retention and reduction in infectious disease, but also reduction in criminal behavior, increase in full-time employment. It is one of the highly effective medications that we have as it relates to opioid use disorders. I think the bright spot that we do have with the opioid use epidemic is a growing armamentarium of highly effective medications. And when done in a quality way, methadone treatment programs wrap not only medication, but look at addressing other medical conditions, but also ensure that people have access to behavioral therapies and other recovery supports.
Okay. Dr. Frank, what are the advantages and disadvantages of using methadone to treat opioid addiction?
Thank you for the question. As Director Botticelli said, it's first and foremost, it's extraordinarily effective, and that's a huge advantage. It is administered in a highly structured environment that provides testing support and therefore has a very low probability of diversion. Now, this structured setting is there because of the way methadone is metabolized, and careful attention to dosing is necessary early in the treatment because of increased risk of mortality. And a disadvantage is that methadone is particularly prone to stigma.
Okay. Another drug used for opioid addiction is buprenorphine. This drug is a synthetic opioid and a DEA Schedule III drug. Buprenorphine can be prescribed by physicians who received a data waiver. They're only permitted to treat a maximum of 100 patients at a given time. Dr. Frank, can you talk about the evidence base for buprenorphine and its impact on overdoses and other health outcomes?
Yes, thank you. There have been 16 clinical trials on buprenorphine. It's impossible to pronounce, isn't it?
Oh, it is, sir. Although, we're learning.
Buprenorphine.
People who think members of Congress can't learn, they still are.
But there have been 16 trials of buprenorphine-based medication-assisted treatment. They consistently show strong effectiveness in treatment retention and reduced illicit opioid use. They also show improved maternal and fetal outcomes in pregnancy relative to placebo trials, and they also have some mortality benefits. So they've also been highly effective.
Okay. I understand that an injectable drug called Vivitrol also has been approved by FDA to treat opioid addiction. Vivitrol is an opioid antagonist, meaning it blocks opioid receptors. It's neither a narcotic nor a DEA scheduled drug. Director Botticelli or Dr. Frank, can you comment on the evidence based regarding the use of Vivitrol in the treatment of opioid addiction?
Once again, there's significant study to show that injectable naltrexone is highly effective in terms of dealing with opioid addiction. I think the premise here is we have 3 really highly effective medications that are underutilized. But it's also, I think, important to understand that as in any disease, you want as many highly effective medications as possible. So to make sure that we're matching the right treatment with the right person, and that if one fails, you have another option to be able to use for people. So, again, I think our approach is to ensure that people have access to all of the 3 FDA medications that we have.
Is there a problem with diversion of those, either of those drugs? Because I know you said earlier the testimony methadone wasn't. Diversion from these 2 drugs?
Clearly, and I think it would be disingenuous to say that there is not a diversion issue with, particularly with buprenorphine. However, what we see when it's done in a high-quality way, when it's done with sufficient patient monitoring, that it is particularly effective in terms of the work that we see.
Okay. Mr. Chairman, and I think buprenorphine, I think I can get that done.
Chair, thanks, gentlemen. Now recognize the gentleman from Indiana, Dr. Bouchon. 5 minutes for questions.
Thanks, Mr. Chairman. As background, I was a practicing cardiovascular surgeon for 15 years, and my wife's an anesthesiologist, so I have a little bit of experience prescribing and seeing patients on these medications. And now I kind of get my medical knowledge through my wife, and as an anesthesiologist, when patients come to surgery these days, it is amazing the number of people who are already on prescription narcotics for a variety of reasons. It's just striking, as well as others like benzodiazepines, but we're addressing the opioids today. The other thing is this does go across Socioeconomic class, it goes across ages. For example, the #1 prescribed medication under Medicare Part D is a prescription opioid pain medicine. That's seniors. So this is really a problem we need to address, and it really is something that I'm really happy that we've chosen to have this hearing amongst many others today, and in the past and future. But enhanced provider education is another priority for reversing the current epidemic. As a provider, I can say that that's true. By really reducing inappropriate prescriptions of opioids. So what steps should be taken to strengthen prescriber training in primary care, outpatient opioid treatment, and methadone clinics for the use of non-opioid methods of managing pain, and also non-opioid things like Vivitrol and other medicines in the recovery of opioid addiction? You can, Mr. Botticelli, you can start that.
Maybe I'll start, and I'll let Dr. Frank talk about HHS efforts in this domain. As the Congresswoman from Indiana pointed out, that a 2012 study by the CDC showed that we were prescribing enough pain medication in the United States, not just in Indiana, to give every adult American 75 pain pills. And while we clearly want to make sure that pain is treated in the United States, when you look back over the past 10 years, all of the morbidity and mortality is directly correlated to the increase in prescribing. So we know that giving people good education is important. That is why we continue to pursue mandatory prescriber education, and I'll yield to Dr. Frank to talk about HHS efforts in those domains.
Let me mention 4 things that we think are important. First is continued bringing prescription drug monitoring programs into the clinical world so that we can track prescribing patterns as part of routine medical practice and can do so across states and across settings. So that's one thing. Second thing is we are in the process of developing guidelines for prescribing, particularly for non-cancer pain. And we have accelerated that effort and should be putting those guidelines out early next year. We've just had a set of public meetings where we've rolled out some initial ideas and gotten public feedback on it. Third is we are engaging with a variety of medical societies and specialty groups to find ways and to partner with them to up the amount of training that's done within each of their organizations. And then finally, for the second year in a row, we've brought together the 50 states to compare best practices for helping to improve prescribing and monitoring of prescriptions.
I think that's really important. I can tell you my own medical training in medical school, and honestly 7 years of residency, I never had a specific month or week even directed at how to manage pain, and that's a person who's a surgeon. So we really learned how to manage pain almost on the go, so to speak, and I think addressing that issue with probably with accrediting agencies that accredit medical school training or residency training is another avenue. But I can tell you as a physician, it takes months or maybe even years to understand how to manage pain. And whether that's non-surgical, whether that's related to injury, and top that off with managing people that already have significant issues with using prescription medication and trying to manage their pain, that we clearly need to address training, probably all the way back to medical school moving forward, and that may take us a generation to fix. So I yield back. Thank you.
Chair thanks the gentleman, and now Chair recognizes a gentleman from North Carolina, Judge Butterfield, 5 minutes for questions.
Thank you very much, Chairman Pitts, and thank the witnesses for your testimony today. Let's see, where do I start? All of you are right. All of my colleagues are right. All of the witnesses are right. We have a crisis in this country. It is preventable, in my opinion, and so it's therefore incumbent upon all of us to address the opiate epidemic that has claimed too many victims in my district and in your districts and all across the country. Opiate addiction doesn't discriminate. It does not discriminate. Black, white, rich, or poor, anyone can succumb to opiate addiction. And that presents a very difficult challenge to finding ways to curb the epidemic. My home state of North Carolina has seen a 300% increase in death increase due to opiate poisoning since 1999. Our emergency officials where I live in Wilson, North Carolina, respond to overdose calls every other day on average. In March, police in the city of Greenville, North Carolina, responded to 6 heroin overdoses in a single day. This is real. It's a real problem which reaches each and every community in our country, from the most urban to the most rural and across every demographic. There's much that we can and should do in response to this significant problem. Recently, I received a letter from our Attorney General, Mr. Roy Cooper, and 37 other state attorneys general, urging members to support legislation to assist with recovery from opiate addiction. One of the provisions important to my state included in that legislation is funding to increase access to Naxalon for first responders. This drug is a life-saving treatment which can counteract some of the damages of narcotic overdoses. And so I appreciate the convening of this hearing to consider some of the policy options to combat this dangerous national epidemic. While some of these pieces of legislation are steps in the right direction, we must consider increasing access to Naxalon, and I may be pronouncing that wrong, for law enforcement. It's also clear that we cannot do this alone. The private sector is a key stakeholder and is stepping up to the plate. From abuse deterrent formulations to injectable and implantable treatments, the future of medicine can help reduce prescription drug abuse and diversion. But let me underscore the urgency of doing it now. From 2001 to 2013, there was a 3-fold increase in deaths from opiates. And the doctors in the room, I appreciate you helping to put a spotlight on this problem. There's been a 3-fold increase in deaths from opiates. These are our nation's mothers and fathers and sisters and brothers. This is a crisis. To Director Botticelli, thank you for your testimony. Are abuse deterrent formulations having an impact here in the United States?
One of the areas that we continue to evaluate is the how abuse deterrent formulations will diminish people's use. I think we're continuing to work with the FDA to look at the evaluation strategies, but clearly we know that this is a prime strategy that we have been putting forth in our prescription drug abuse plan to really look at the impact that abuse deterrent formulations will continue to play in reducing prescription drug use issues. I think as you discussed that abuse deterrent formulations are one part of a larger strategy that we have to employ in terms of dealing with this issue. Clearly, we don't want people just switching from one drug to another. We want to use that as an opportunity to get people into care and treatment. So this is obviously a prime part of our strategy, an important part of our strategy that has to be linked to other things to ensure that people get interventions and get good, high-quality care.
While I have your attention, let me talk about manufacturers just for a moment. Can you describe whether we should be doing more to encourage opiate manufacturers to convert their medicines to abuse deterrent formulations?
Mm-hmm. And I probably can't speak as eloquently as the FDA can on this issue, but clearly they have signaled their strong preference for approving abuse deterrent formulations as part of their overall goal and work that they are doing. And again, it has been clearly part of our overall prescription drug abuse strategy to continue to promote abuse deterrent formulations.
Thank you. Now I'll go to my far right. Now, we don't use that word in this room, do we? All right. Go to the right. All right. Deputy Administrator Riley, as a representative from an area which has withstood some of the strongest storms in our nation's history, I'm concerned. I'm interested in the Medical Controlled Substances Transportation Act of 2015. I know you recognize that. Can you describe whether this legislation would increase access of potentially life-saving treatments to those in need of federally declared disaster areas?
Well, clearly in situations, unfortunately, that the Carolinas are going through now, it's an important aspect. While I don't know the specifics of the bill, I can tell you that we're working with the committee on this. We recognize this is an issue that really needs attention, and I give you my word we're gonna come to some agreement here. We'll work it out.
Mr. Chairman, you've been very patient with me. Thank you. I yield back.
Sure, thanks, gentlemen. Now I recognize the gentleman from Florida, Mr. Bilirakis, 5 minutes for questions.
Thank you so much. I appreciate it. Thanks for your testimony, panel. I have a question for Mr. Riley. Recently, as many of you discussed in your testimonies, heroin deaths have been increasing across the country at an alarming rate, unfortunately. Both Pinellas and Hillsborough counties in Florida, which I represent a portion of both those counties, they've seen heroin deaths rise, in some cases by more than 700% over the course of a year. Unbelievable. Mr. Riley, what can we do to best address not only how to control the supply side of prescription drug abuse, but also address the demand issue so that this population doesn't turn to illicit drugs?
Thank you for the question, sir. Well, I think you hit it on the head. While I've been in law enforcement for 30 years, I do recognize we cannot arrest our way out of this. This is an issue that can be found in every corner of this country, in cities large and small, rural and urban. And we've got to get everybody's help, from law enforcement to policymakers to educators, faith-based organizations, clearly treatment, and the registrants that handle prescription drugs. So it's an educational fight as much as it is, I think, a law enforcement fight. Now, on the law enforcement side, I also have to tell you, we have never seen organized crime, and I'll use the Sinaloa cartel. We have never seen, in my 30 years, a criminal entity so well-financed, vicious, and willing to do anything to make a buck. What keeps me up at night, sir, is the growing relationship between American street gangs, urban street gangs, and the toxic business relationship that they have formed with Mexican organized crime. That in itself, I think, has fostered the spread of heroin across the country. Today's heroin is not what it was 5 years ago. It's cheaper, it's more pure, it can be smoked and snorted, so it has really attracted a completely different user base. So this is everybody in this room plays a role in our success. And that's why I applaud this committee for even bringing this up. But I can tell you, DEA around the world, working with our partners, it is the #1 priority. One of the things that we're doing better, sir, that we haven't done before is we're communicating. The bad guys for years have counted on the cops not sharing information, not sharing intelligence information. We're doing that better now than we've ever done it, even with our foreign counterparts. I've spent quite a bit of time on the border and also in Mexico. I have to tell you, we've never seen the exchange of information with the Mexican law enforcement authorities as good as it is. Our ability to share information and for them to share information back for domestic cases is at an all-time high. So I am optimistic on the law enforcement front that we're moving forward, but clearly everybody has a piece of this.
Thank you. That's good to know. Mr. Botticelli, you mentioned a steep rise in the number of babies born with neonatal abstinence syndrome. Counties within my district were found to be suffering from some of the highest number of babies born addicted to opiates in the country. What do you see as the greatest obstacle to ensuring access to services, and how can these challenges be addressed?
So again, this is, I think, an opportunity for us to work with Congress on additional issues, particularly the Protecting Our Infants Act that was passed in the House, and I think it's a really great opportunity to expand our efforts. So clearly, you know, we have, as you have indicated, have seen a dramatic increase in the rise of pregnant women and neonatal abstinence among babies who are born here in the United States. You know, obviously our overall efforts to focus on reducing prescription drug misuse and heroin use play a big role, but also making sure that that pregnant women have good access to care and treatment. We have effective medications, again, for the use in this, and that moms have particular particularly good access to a wide variety of treatment services. So this becomes really important for us to look at this. We also want to ensure that we are not putting additional stigma on pregnant women in terms of their ability to seek care. And we hear that time again. Dr. Frank talked about the role that stigma plays. But that is particularly true with pregnant women, and we don't want to do anything to further enhance that, particularly among pregnant women in terms of their ability to seek care.
Thank you, sir. Would you be willing to come to my district and participate in a roundtable on this particular issue?
Absolutely.
I'm in the Tampa Bay area.
Great to do that. I've had the opportunity as I've traveled to talk and visit many neonatal intensive care units, had the opportunity to talk to practitioners. I think we have further work to do, and this is where we're looking forward to working with Congress on making sure that we have good standardized protocols for the treatment of pregnant women, that we have good surveillance. And so again, I think this is another area where administration priorities and congressional priorities are aligned.
Absolutely. Thank you very much. I yield back, Mr. Chairman.
Chair, thanks the gentleman. Now recognize the gentleman from New Mexico, Mr. Lujan, 5 minutes for questions.
Thank you very much, Mr. Chairman. I appreciate this important hearing today. And Mr. Chairman, my questions began with Dr. Frank. Looking specifically at the legislation that I've introduced, Assistant Secretary Frank, to see what we can do in especially rural states like New Mexico, where it's hard to get to some of these areas and families are being separated because of the challenges of substance abuse, which is compounded by these distances and healthcare shortages. What are we doing to ensure that those in need of help are getting it? How do we make sure people don't have to wait 3 months to be able to get access to this care? And how do we make sure that rural communities are not left behind?
Thank you for that question. As you probably know, Secretary Burwell, being from a rural area herself in West Virginia, where the opioid abuse and mortality rates are very high, is extraordinarily sensitive to these issues. And one of the things that is behind our new grant program, putting $100 million into community health centers to increase access to buprenorphine, is to actually get more services, more people trained into the areas of high need and low availability. And so that is a major thrust of what we're doing there. The other is to sort of revisit our rulemaking on access to buprenorphine and other medication-assisted treatments, so that we can increase the number of doctors, potentially increase the physician capacity to treat opioid use disorder.
And Dr. Frank, can you quickly touch on the importance of how we should consider giving states flexibility when it comes to treatment programs? There's a program in a little community in my district in Espanola called Inside Out that talks about the length of times that it takes to get treatment. And many judges in New Mexico are requiring 6-month treatment programs. There aren't very many 6-month treatment programs, and the only ones available are if you get incarcerated. So we're spending money to put someone in jail and not putting that money into treatment for these individuals that are addicts.
Yeah, thank you for that question. Actually, I've been there, and I think that it is important, and in fact, the reason that we're using grant mechanisms is in part to allow us to kind of match the interventions and match the strategies to the local needs, and in particular, making sure that the patient is at the center of what we do, and their circumstances kind of dictate the way we put the treatment in place.
Inside Out also makes the important point, as we talk about naloxone or Narcan, that what can we do to make sure that that's readily available? It's about the safest substance, as we talk about these treatments that someone can take. Is there a push, or can Congress do something to make that available over the counter as opposed to not being a prescription mechanism? Because some of these addicts are, when there's an emergency or an issue, you have to go try to get a prescription. They need it then and now to save their lives. What are your thoughts there?
As you indicated, increasing access to naloxone by anyone who's in a position to reverse an overdose has been a particularly important priority for us. We have been working with law enforcement across the country, have really been heartened to do that. We have been significantly heartened by the number of states, including New Mexico, that have passed naloxone distribution efforts. We are continually to support and will, in the President's FY16 budget, naloxone purchase. SAMHSA sent out a letter to states saying that some of the existing grant structures can be used to help support naloxone purchase. So that will continue to be a priority for us to look at how we increase the capacity for naloxone and look at supporting grant programs to look at increased naloxone purchase.
And Mr. Riley, I'm trying to do the math here. Everything that I read suggests that 90% of the poppies in the world are grown in Afghanistan, or the opioids are produced in Afghanistan. So that leaves 10% for the rest of the world, and it's been grown in lots of places. 90% of the heroin coming to the United States is attributed to Colombia, Mexico, with 50% going to one cartel. So you're am I to understand that with less than 10% production or a fraction of that production, Mexico and Colombia are growing their own poppies that lead to 90% of heroin that's coming to the United States? Or is there opium coming from Afghanistan to Mexico and to Colombia that's making its way to the United States? And if that's the case, how do we stop it?
Well, I can tell you that the majority of the opium and heroin produced in the Afghanistan theater is destined for China, Russia, and Europe. We see as little as 5% in the United States, but clearly between the Colombians, criminal organizations, and the Mexican criminal organizations, they control virtually all of the heroin available across our country. And what are we doing to ensure that? I go back to the cooperation that we have, sharing intelligence information, making sure that we work on organizations. For us to be successful, we have to stop the street level, which leads to violence, but at the same time, we have to ensure that we follow those cases wherever they take us, whether it's into Central South America, working with our counterparts overseas, our agents on the ground, to stop it at the source. And at the same time to go after the reason they're in business. And clearly that's the profit. And that is just as important part of what we're doing. So are we getting better? I certainly feel we are. But as I said before, this is a marathon, not a sprint. We're in it for the long haul, but we need everybody's help.
Gentleman yields back. Chair recognizes the gentlelady, Mrs. Brooks from Indiana. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you all for your work on this issue. Mr. Botticelli, as I mentioned in my opening and as you also talked about, we have an issue with respect to the prescribing practices beginning with medical school education, or not just with med schools, because it's not just physicians who are prescribers. It's there are a whole category of healthcare providers who are providers or who are prescribers. In ONDCP's 2011 report, 4 years ago, it was epidemic, responding to America's prescription drug crisis, and one of the issues in that report was that we were going to encourage medical and health professional schools to continue expanding their continuing education programs to include instruction on measuring pain and prescribing to treat it. What efforts have been made since 2011, if not before, with our medical education schools? And because I talked to our med school in Indiana just a couple of months ago, and still yet less than 5 hours, if even 3 hours, of education is dedicated to those who are prescribing. What is the resistance? Why are our medical education providers, not just for physicians, but for nurses and for nurse practitioners and others, what's the resistance, and why haven't we gotten that done?
There are two issues that you and Dr. Prashant have articulated. And I think one is getting to the root cause about how do we make sure that healthcare providers, not just physicians, but nurses, have embedded in their training programs good information on substance use disorders and safe prescribing. We've actually been working with the American Board of Addiction Medicine and all of the medical specialty medical societies and the AMA, as well as the deans of medical schools, to look at embedding good medical education as part of their curriculum.
Excuse me for interrupting, but why hasn't it been done yet when we've known for now a number of years this has been a problem? You all identified it, at least in 2011, if not before. What is their resistance in embedding it in their curriculum this academic year? Why isn't it there yet? And what do we need to do with our state medical associations, with the medical school associations and so forth? What do we need to do to get it embedded in education initially? Healthcare providers don't want to be helping cause the problem, but yet when they give a 30-day prescription for a pain med after a minor procedure when you might need 4 to 6 or 7 days, I don't know, doctor, why do we give 30 days of prescription? Yep. Why are the med schools resistant?
Having been doing this work for quite a while, I think there has been just an overall hesitancy and resistance to think about substance use disorders as part of someone's overall health conditions, and not seeing the impact of what we're seeing. You know, when we look at treatment, referrals to treatment, only 7% of referrals to treatment are coming from our healthcare providers. And I think we will continue to pursue opportunities, not just to embed medical education, but look at the testing requirements of those medical educations to make sure that we're having competencies as part of medical examinations. And this is why I think, you know, being into this epidemic, why we've been calling for at least for mandatory education. We've seen states, about 10 states, have passed medical education laws as it relates to pain prescribing, and we're seeing some remarkable results.
Excellent. Could you please provide us with the list of which 10 states have done that? Because that is something that I'd like to explore further.
Happy to do that.
Mr. Riley, I want to thank you for your many decades of service with the DEA. I'm a former U.S. attorney, and from 2001 to 2007, crack cocaine was the epidemic of the day in the 80s, 90s, and early 2000s, but it's obviously shifted. And I'm curious, because the synthetic drugs that are coming into this country, you said in your testimony, in written testimonies, primarily from China, and while we have this unprecedented, I'm curious about the unprecedented cooperation with Mexico. Really? I'd like to know a little bit more about why is it so much better now than it was 5 years ago, and how is China cooperating with us with respect to synthetics?
Thank you, ma'am. In terms of China, we are beginning to make inroads there. It has been a tough road. Many of the synthetic drugs that are seized here are very difficult to origin, and that's by design. But we have made inroads. We've had several high-level meetings with the Chinese on this issue, dating back, I think, several years ago. So this is an ongoing dialogue. Part of our issue there is, as it has been in Mexico, is to make sure both the Mexican authorities and the Chinese authorities understand the damage that it's doing in the United States. In terms of our Mexican partnerships, I was the agent in charge of El Paso in the mid-2000s when Juarez was aflame. Thousands of drug-related homicides. We have really developed a working relationship with part of the Mexican authorities, not all of them, unfortunately, but we've developed a working relationship that's based off trust, that's based off productivity, and I think they understand the importance that they can play in both their own country and around the world. Our extraditions continue to be strong. Just a couple of weeks ago, we were able to pull out 2 very high-level targets that I got to tell you, 5 years ago, I don't think they would even consider doing it. So it's an ongoing process, ma'am. It's what keeps me up at night. I'm really 35 years old, but this is what it's done to me. And I give you my word, around the world, our guys 24/7 are on it, because it truly is the new face of organized crime.
Mr. Chairman, before I yield back, I just want to commend the agents of the DEA who I've worked with for quite some time, and they do remarkable work. There just aren't enough of them, and I don't think we give them all the tools they need. And with that, I yield back.
Chair, thanks, gentlelady. Now I recognize the gentleman from Massachusetts, Mr. Kennedy. 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Riley, a couple of questions to start with. Ms. Brooks and Mr. Lujan touched a little bit on the origins of the opium trade and heroin trade internationally. And I was wondering if you could quantify, to the best of your ability, the total dollar figure, if you will, between the U.S. and Mexico for heroin.
Well, it's very difficult to do, but I can tell you it's in the billions.
Order of magnitude, just so, and I don't mean to put you down too much, but $1 billion, 10 billion, 100 billion?
Definitely in the close to 50 billion. And I quantify that by saying just in Chicago, where I was the agent in charge, and heroin has exploded in the last several years, it was billions of dollars when we really drilled down on it. So, and I think that's what's really important. And if you look at New England in particular, you're seeing the spread of violent organized crime urban in terms of street gangs, and their ability to interface almost as unwitting contractors with Mexican organized crime, to put heroin on the street, to make it available, and obviously causing violence. I mean, the way these organizations regulate themselves serves with the barrel of a gun. And I think it has caused tremendous damage across the country.
Mr. Riley, thank you, and thank you for your service. I want to touch on two other things, just commend you briefly. For bringing back, first off, the take-back days. And one day, back on April 26th of 2014, Massachusetts residents alone on a single day dropped off nearly 23,000 pounds of drugs. And I believe nationally the figure was 390 tons in that single day. I think they're a tremendous attribute or asset for our country, and I appreciate you bringing them back. I also want to thank you for your work with New England and around the HIDTA designation, the high-intensity drug trafficking area. It's helped with critical resources for law enforcement in the region, and I want to thank you and commend you for that. Dr. Frank, or Mr. Frank, excuse me, I wanted to touch base with you a little bit, if I can, somewhat briefly, and I apologize. There's 3 FDA-approved medications for treatment of opioid dependence: methadone, buprenorphine, and naltrexone. I'm interested in learning a little bit more from you about methadone, if you will. So could you describe a little bit about how methadone is used to treat individuals with opiate dependence?
So methadone is a very powerful drug. It's a controlled substance. It is provided in a very controlled setting, so-called OTP, opioid treatment programs. That are very comprehensive. They provide the dose in person on the day. They provide counseling. They provide drug testing. They provide patient monitoring. And I think I said earlier that the reason that this is done is because the dosing and the management of methadone, particularly at the beginning of a treatment episode, must be done very carefully or risk mortality.
And there's special restrictions on the prescription or the ability to prescribe?
Yes, there is.
And what are they briefly, if you can?
They have to be done within those programs, those certified programs.
And are those requirements applied to the treatment of individuals with opiate dependence with naltrexone or buprenorphine, or is the regulatory schema different?
Yes, the regulatory schemes are quite different. The naltrexone sort of operates under the rules of Data 2000, and did I say naltrexone? I meant buprenorphine. And naltrexone is not a controlled substance, and so it can be prescribed by any physician.
And is there a medical rationale to separate the way that those drugs are actually regulated?
I think there is. As I said, I think there are unique risks in the particularly the early stages of methadone treatment. Buprenorphine, as we've noted, is a drug that is a controlled substance, and there is diversion of that drug. And because naltrexone is not a controlled substance, it can be more broadly prescribed. So I think there is a logic to it.
So if I can squeeze one last question in here, do you think is that separation of that different regulatory environment make sense, or do you think bringing it all together and putting it under one, basically abolishing the stovepipe regulations there, makes sense, or is there rationale for keeping them separate?
I think you can. I think that even if you brought them together, you would see many of the same restrictions in place. I think that what we're trying to do is particularly focus on buprenorphine right now, because I think that's an opportunity we have to rethink those rules so that we can expand access to MAT.
Thank you very much, sir. Thank you, Mr. Chairman. I yield back.
Chair, thanks to gentlemen. Because Dr. Murphy is chairing a hearing downstairs, Mr. Guthrie's yielding him his 5 minutes. Dr. Murphy recognized.
Thank you, Mr. Chairman. I appreciate that. I wanted to be here because although downstairs we're having a hearing about Volkswagen and devices put in cars that affect emissions testing, this is a life and death matter. So I wanted to be here. First thing I wanted to ask, Mr. Chairman, I ask unanimous consent that this letter signed by multiple members of the Energy and Commerce Committee be submitted into the record. It was sent today to HHS and calls for a comprehensive review and additional rules on buprenorphine providers before HHS unilaterally lifts the data provider cap.
Without objection, so ordered.
Thank you. Now, I would just want to make sure none of you are physicians, none of you are people who are involved in the treatment of people with addiction disorders. Am I correct? Okay. But you're involved with policy making on these issues, correct? Okay. I'm a psychologist. I've dealt with people with addiction disorders. And I want to start out by saying one of the problems that we have in this country is that money that is sent to states that is being used for mental health funding for block grants and substance abuse block grants are not allowed to be used together. The serious problem that comes with that is many people with substance abuse disorders also have mental health disorders. And yet we create a barrier there. Now we're talking about increasing the number of prescriptions a physician can write. Dr. Frank, do you know how many, so we're talking about someone going from like 30 or so a month, a week, a day, what is it, up to
30 patients at any one time.
30 up to 100, and they can petition to go beyond that. See a maximum with that?
Right now, there's a limit to 100 after a year.
Right, but after that, they're looking to do more. They want to lift that cap. Right?
We're in the process of sort of reviewing the best way to expand access, and we're going to do it very, very cautiously.
I understand. To what number?
We don't have a number yet.
Okay. Now, throughout this process, recognizing that buprenorphine is the third most diverted drug, that is, people get it and they sell it, and they make money, and then they'll go out and buy heroin or something else. What attention is being given to make sure that doesn't happen?
That is exactly why we're taking a careful approach, because of that concern. But let me give you an additional concern. So we want to expand access. We are concerned that too often you don't get the full package of services, the counseling, the supports, and then the testing and monitoring. And so we want to make sure that the evidence-based package is in place and that the risks of diversion are minimized. And so what we're trying to do is to collect evidence about where the places and under what conditions are you most likely to be able to significantly expand capacity while minimizing the risks of diversion and maximizing the probability that evidence-based treatment will be provided.
So let me ask about some of those. How much time do you think the average amount of time is that one of the physicians who's prescribing will actually be face-to-face with a patient?
I think
well, let me help you with this way. Is that something that will be assessed?
Yes. Well, we want to consider sort of what it takes and what are the environments that get you the combination of treatment. So that means you have to have the counseling, you have to have the...
Right. Well, let me go into a couple of things. I talked to some people, one clinic, and they said the average amount of time physicians may spend actually discussing and prescribing is about 1.5 minutes. Now, during that amount of time, you have to assess those very things. Is this a diversion issue? Is the person in recovery? Are they seeing a counselor or a therapist? Are they really engaged in treatment? And also that in many of these cases, the person who is perhaps the addictions counselor does not even communicate with the physician except maybe to write a note in the chart in treatment. Or they may have someone there in some places where it is a nurse or someone sitting in the waiting room,
And while people are there waiting for their prescription, they have a chat and they write that down as group therapy. You're aware that some of these things take place. And knowing you, I would assume you would be as distressed as anyone to say that is not tolerable, that is not treatment. And such people not only should not have expanded prescription privileges, they should have zero.
I completely share your concerns, but even more importantly, Secretary Burwell shares those concerns.
Yes, she does.
And she has emphasized sort of a careful approach to make sure that both the evidence-based treatment and the risk of diversion are addressed carefully.
One final thing in my final seconds here, and I know Secretary Burwell is dedicated to this too, but I'm also concerned that the amount of training that these physicians get dealing with addictions is minimal. Very few of them are actually addictions counselors, addiction trainers, and many times other people there have minimal training. In my area of southwestern Pennsylvania, I've heard proctologists, plastic surgeons, pediatricians, and others who do not have extensive board certification of these things. I think it's a dangerous issue for something that is growing as a deadly issue in America. And I hope we can continue our conversation. I want to work with you on this, but we are all concerned that just expanding the number of prescriptions can be written without total assurance these other things is a dangerous issue. Thank you, and I yield back.
We thank you for your support and agree.
Chair, thanks to the gentleman. And now I recognize the gentleman from Maryland, Mr. Sarbanes, 5 minutes of questions.
Thank you, Mr. Chairman. I want to thank all of you for being here today. I've introduced the Co-Prescribing to Reduce Overdoses Act, which would create a demonstration project to encourage co-prescribing opioid overdose reversal drugs like naloxone. So let me talk a little bit about the need first, which you all are very familiar with. Over 100 Americans every day are dying from preventable drug overdose, and that kind of fatality is now the leading cause of accidental death in the country. In 2013, more than 16,000 people died due to prescription opioids overdose, and an additional 8,000 died from heroin overdose. In Maryland, we're having the same experience. We had 192 heroin overdoses in the city of Baltimore. In Anne Arundel County, which I also represent, there were 49 fatal overdoses from opioids. And that was part of 360 overdoses overall that occurred. So this is an epidemic, there's no question about it, and we have to put real resources behind it. We have to put it behind workable and strategic solutions that we can identify. I'll mention that today the state of Maryland released a $608,000 grant from the U.S. Department of Justice to help address this epidemic in our state. Let me talk about naloxone now. It's a drug that safely and effectively reverses both opioid and heroin-induced overdoses if administered in time. It has been used by non-medical personnel with only minimal training for over 15 years and has been proven to lower overdose mortality by almost 50%. More people need access to life-saving medication, obviously. And while efforts to distribute naloxone to first responders and community organizations are important, and we've talked about that today, it's critical that we also take a more proactive approach. One part of that proactive approach is the idea of co-prescribing naloxone to patients who are taking opioids and are at high risk of overdose. And this is supported by the American Society of Addiction Medicine, the American Medical Association, the Veterans Health Administration. The bill that I've introduced, the Co-Prescribing to Reduce Overdoses Act, would create a demonstration project for federally qualified health centers, opioid treatment centers, and other providers to encourage co-prescribing naloxone. Funds could be used for training, to purchase opioid overdose reversal drugs, to offset co-pays, and to conduct community outreach and raise awareness to connect patients who have experienced a drug overdose with appropriate treatment and track individuals that are participating in the program. And all grant recipients, of course, would be required to evaluate the outcomes of the program. A second program would allow states or local health departments to develop guidelines on co-prescribing opioid overdose reversal drugs like naloxone. So there's no question that opioid overdose is a public health epidemic. I believe strongly that increased access to naloxone particularly this co-prescribing opportunity to patients at high risk of overdose, is a key element of any approach to successfully decrease prescription drug and heroin overdoses. I'd like to get the thoughts of the three members of the panel, certainly Mr. Botticelli and Dr. Frank, on this question of whether co-prescribing naloxone is an effective strategy that we should try to encourage and support going forward.
Thank you for your leadership on this issue. I don't think we could agree with you more in terms of the opportunities that we have for supporting co-prescribing in a wide variety of settings, and in particularly for people who are at highest risk. We share your goals. We have actually continued to take action to support co-prescribing. We've hosted webinars with the American College of Emergency Room Physicians to support co-prescribing. We continue to work with our treatment programs to encourage co-prescribing. So this is, I think, a particularly important area for people who are at high risk. Our overall policy goals are to ensure that anyone who is at high risk for an overdose also has access to naloxone. It's been truly remarkable in terms of its ability to save lives and actually motivate many people to go seek care and treatment. So we'd love to continue to work on that, to look at that legislation.
Dr. Frank, I have 15 seconds if you have a comment.
Yeah, obviously I'm not going to say what he said, but there are some things that you need to do to go along with co-prescribing and other measures to really expand supply here. And one of them is making sure that we have user-friendly versions of naloxone so that non-medically trained people can administer it. Two, I think we need to make sure that once somebody gets naloxone, they get to treatment. Just recovering and walking away isn't the right thing to do.
No, it's the first step is what you're saying.
It's the first step, and it's an important first step, but we'd like to complement that with links to treatment.
Great. Thank you. I yield back.
Thanks, gentlemen. Chair recognizes Mr. Lance, 5 minutes for questions.
Thank you, and good morning to the panel. Mr. Riley, did you say you're 35 years old? Is that what you said? Yeah. Yes, I'm 35 as well, but what keeps me up at night is leadership elections. You discussed challenges in carrying out a criminal prosecution pursuant to the Federal Analog Act. It is my understanding that there is a very high burden of proof to establish that a compound is in fact a controlled substance analog. Could you please elaborate on that standard and what changes can be made to the Analog Act that would make it more effective as a tool in combating the spread of synthetic drugs?
Well, first of all, just the mere amount of the synthetic drugs that we're encountering is mind-boggling. And our ability to test those through our scientific arm and get an identifier on them sometimes is very prolonged. So what we're doing now is we're really trying to look at how can we be effective, what is the best possible way that we can move this process along. But I've got to be honest with you, we're not one step behind the bad guys, we're 3 steps behind the bad guys.
Thank you. Is there anyone else on the distinguished panel who would like to comment on this?
I completely agree. I think it's been a challenge from both a prevention standpoint and a scientific standpoint to stay ahead of the chemical tweaks that manufacturers make to do that. I think that opportunities to lower the burden of proof around scheduling, around these analogs are important. I think despite Congress and state best attempts to deal with this issue, that look at expediting the scheduling and thinking about the criteria with which we schedule those drugs is particularly important.
Thank you. Director Botticelli, as you mentioned in your testimony, New Jersey, where I live, is one of a handful of states that requires greater use by prescribers of the state's prescription drug monitoring program. Mm-hmm. Specifically, Governor Christie recently signed into law a requirement for prescribers to check the program when patients return for a second refill on a prescription opiate. What is your office doing to ensure that both state officials and prescribers are able to utilize effectively their prescription drug monitoring programs?
So I'll start, and I know that this is an important initiative for the Secretary to do, so there's more action.
Certainly.
When this administration started, we had 20 PDMP programs, 20 states. Today, I'm happy to report that we have 49 states that have prescription drug monitoring programs. We continue to focus opportunities on increasing the interstate operability so that we can share information across state lines, but also increase the utility and usability of these programs. And I'll defer to Dr. Frank on that. But one of the things that I think we're seeing promising practice, and particularly in states that require some level of mandatory check of the prescription drug monitoring program, we're seeing a decrease. In Florida, we saw a significant decrease in overdose deaths, and we've seen a significant decrease in doctor shopping, people going from one doctor to another to get their medications when we have good, robust prescription drug monitoring programs.
Thank you. Dr. Frank?
This year, we're investing $20 million in state grants really to focus on improving prescription drug monitoring programs in the states. We have a proposal in for 2016 to put in $45 million in order to bring it to all 50 states. We're hoping to build off the progress of some very successful pilots in addition, that have integrated prescription drug monitoring programs and clinical health information technology.
Thank you very much. And Mr. Chairman, I yield back the balance of my time.
Chair, thanks, gentlemen. Now recognize the gentleman from New York, Mr. Engel, 5 minutes for questions.
Thank you, Mr. Chairman. You know, gentlemen, first of all, thank you all for excellent testimony. It's really, all of you have just been terrific. And you know, through my perch on the Foreign Affairs Committee, when I was chairman of what we called the Western Hemisphere Committee, which dealt with Latin America, and we did a lot of work with involving the drug trade in Mexico and some of the other places, and we fund money for treatment programs, and we fund a lot of money to go after the bad guys, but so much of the consumption comes from us that I've always felt that we didn't do enough in terms of education, in terms of that side of it, rather than going after the bad guys after they've done it. And the one thing that's stark for me is that there are so many people in this country that use drugs. I mean, it's just mind-boggling. And young people, because when you're young, you think you're going to live forever and you think nothing's going to happen to you, and so you are more likely to experiment. But this is an epidemic. I mean, this is just beyond the pale, and it really, you know, I don't make judgments on anybody, but I just know that we can't continue like this. I mean, we've got to do a better job of educating people and letting them understand that this is a life-ruining situation. So I'm wondering if, and you've really driven the point home, all three of you, about it. I mean, I have some other questions to ask, but in general, I think, you know, if you can expand on that, because it's really just shocking, the extent of the abuse. And so not only are we keeping these criminal enterprises going, but we're destroying lives of American citizens.
I'll start. Thank you, Congressman, for your comments. I think, you know, what you've described is the entire approach to the Obama administration's view of drug policy, that while supply reduction in law enforcement has a big role to play, that we need and will continue to pay more attention to prevention, treatment, and recovery efforts for people here in the United States. If you look at our entire drug control budget, we are actually spending now more on those public health strategies than we have had during the entire time of our office. So this is particularly important. I will say, however, that I think our heroin situation is a good example between the nexus of supply and demand, that because of the purity levels, because of the price, because of the widespread availability of heroin that we have, it really does combine both a public health and public safety approach. And I've really been heartened as I travel around the country to see law enforcement and police wanting to partner with public health to really come up with holistic strategies, knowing that arrest and incarceration are really ineffective in dealing with this issue.
You know, every time I see a young person smoke a cigarette, a regular cigarette, I think to myself, you know, why are they doing this? Because we have evidence now that we didn't have maybe when I was a kid, that smoke, regular smoke, just is terrible for your health. And you think, well, why would a young person do that? We're not getting through. And of course, when you take it a notch up and you're talking about heroin or prescription drugs, it's that much worse. So we're failing as a society, and it's just shocking. So let me ask you, Dr. Frank, the bill proposed by Congresswoman Brooks and Congressman Kennedy tasks an interagency coalition with developing best prescribing practices, and it's certainly needed. My district, New York's Lower Hudson Valley, contains a portion of my district, and according to the New York State Office of Alcoholism and Substance Abuse Services, the number of New Yorkers admitted to hospitals on account of heroin skyrocketed 136% between 2004 and 2013. And in 2013 alone, nearly 90,000 New Yorkers were admitted to hospitals for heroin and prescription opioid abuse. It's just shocking. It's absolutely shocking. So given how varied the populations affected by this epidemic are, how would you, Dr. Frank, suggest that we ensure that any best practices created as a result of this bill or otherwise will suit physicians and patients from contrasting backgrounds? I worry about a one-size-fits-all approach. Do we need to tailor best practices to different populations?
Thanks for that question. Our approach is very much aimed at two things. One is matching policies to context locally, but also matching patients to actual treatments. And we want to do both. And so, for example, this just a couple weeks ago, we had a 50-state convening where we brought all the states together, all 50 states in the District of Columbia together, to talk about how to share best practices. And what we did is we had breakout sessions where we had regional breakouts. So in fact, people who bordered one another could talk about sort of common approaches that met their particular circumstances. Likewise, we try to have a full armamentarium of treatments available so that we can match patients and their circumstances in the best possible way. And our mechanism for doing this is largely grant support through the states.
Thank you. Thank you all. And Mr. Riley, thank you for all you do.
Chair thanks the gentleman. Gentleman yields back without objection. Chair recognizes Mr. Tonko, a member of the full committee, who wishes to ask questions for 5 minutes.
Thank you, Mr. Chair. As I mentioned in my opening statement, access to effective addiction treatment is the biggest obstacle we face today in preventing more deaths in this epidemic. We know that nearly 80% of persons with an opioid addiction do not receive treatment. While the reasons for these gaps are multifaceted, it is clear that capacity in our current treatment system plays some role. A study published recently in the American Journal for Public Health estimated a gap between treatment need and treatment capacity between 1.3 and 1.4 million individuals in the year 2012. This is why I joined with my colleagues in introducing the TREAT Act, which would raise the arbitrary cap on buprenorphine prescribing for certain providers and allow physician assistants and nurse practitioners the ability to be waivered providers. As such, I was very encouraged by Secretary Burwell's announcement to start the rulemaking process to address opioid addiction and specifically address treatment hurdles such as the DATA 2000 caps. Dr. Frank, what is the expected timeline and process for this rulemaking change?
You're not going to like this answer, but we're going to move as fast as we can. But I can guarantee you that this is extraordinarily high on my office's agenda, the Secretary's agenda, and literally we are meeting every week to kind of get this pushed through.
Thank you. And Director Botticelli, we've heard a number of concerns expressed today over the diversion of buprenorphine. Is that the most commonly diverted opioid?
I'll defer to my DEA partners on this in terms of diversion. I would suspect that probably pharmaceutical opioids are far more diverted than buprenorphine diversion.
Okay. And what actions does the administration recommend to address that diversion?
part of, I think, what we need to look at, and I have to be careful not to get ahead of the HHS rulemaking authority here, but I think that looking at how we can continue to support access to buprenorphine and other medications, but also being mindful of ensuring quality treatment and minimizing diversion become really important. And I think you've heard a willingness on the part of the administration to work with Congress on how do we strike that balance as we move forward, thinking about how many people, who can prescribe, what's the quality care setting that we do it. I've seen models across this country where we've been able to expand the number of people who get access to medications through a wide variety of, I think, really innovative state practice. And I think we can use some of that thinking and some of that guidance to help with the process about how we go forward.
Mm-hmm. Let me ask you, Director Botticelli, why do you think we make it so much harder for individuals to get the treatments that help them recover than the drugs that get people addicted in the first place?
I think there's a wide variety of, both as a person in recovery and as someone who's been doing this for a long time. I think stigma plays a huge role. And I think, quite honestly, that we have viewed people with addictive disorders and their families as less deserving of care. And I think for a long time, public policy has reflected that. And I think now, with the opioid epidemic, I think we're finally understanding some of the longstanding issues that we've had in this country as it relates to how we've treated people with addictive disorders. I think that's why our jails and prisons, quite honestly, are, unfortunately, our de facto treatment programs that we viewed people with addictive behaviors as morally flawed or bad people, and I don't think we've seen them as deserving as a response as people with a disease.
Well, I think all of you gave powerful testimony, and it reminds us that we need to see addiction as a disease, and until we do, we won't get the results we require. And finally, Director, does the administration support mandatory prescriber education on pain management and substance use prior to an individual being able to prescribe controlled substances?
We do, and we look forward to working with Congress in terms of how we might make that happen.
And there are things that Congress can do to help with that effort.
Absolutely.
And you'll direct us.
And we look forward to working with you on that.
Absolutely. I thank you all, again, for your testimony. I think it was very instructive. And with that, Mr. Chair, I will yield back the balance of my time.
Chair, thanks, gentlemen. That concludes the questioning of members present. We've had members going in and out all morning because we have another hearing on energy and commerce being conducted downstairs, so apologize for that. But I want to thank the first panel of witnesses. This is a very important issue. We look forward to working with each of you as we proceed on the legislation. And we will have follow-up questions, so we will send those to you in writing. We ask that you please respond promptly. And remind members that they have 10 business days to submit questions for the record. Members should submit their questions by the close of business on Thursday, October 22nd. I have a UC request, a statement for the record on behalf of the Opioid Treatment Program Consortium. Without objection, so ordered. The subcommittee will stand in recess until the week of October 20, when we will convene our second panel on this issue. The subcommittee stands in recess.